Here I'll be speaking about the evaluation of the infertile male, and this is the most neglected fact in reproductive medicine. What we don't realize is we never take a proper history of the male. We don't do a physical examination, and the seminal is done by the least qualified person in the unit. There's no external quality validation. We never consider imaging as a modality of science. And then we rarely know when to order a hormone evaluation. And then we never know when to order a DNA fragmentation. And on top of it, we never know how much it costs to do a proper male workup. That means half of the whole reproductive medicine we are ignoring. In this, the reason is why should the couple come to a clinic together? There is a concept called fertile, subfertile, and infertile. If both the couple are highly fertile, they conceive quickly. If one of the partner is subfertile, they take time. And if one of them are sterile, only technology will help them. But we never look at it from that point. Every infertility patient, you should look at it as this box. On the vertical axis, you have the male reproductive function, absent function, impaired function, optimal function. When it comes to the female, absent function, that means absence of uterus, ovary or tube, impaired function, optimal. So when both the partners are highly fertile, they conceive quickly. If the male partner is impaired and the female partner is optimal, then you move into this chart. That means with the appropriate treatment, they conceive in 3 to 6 cycles. When both the partners have impairment of fertility, then they fall into this group. Then they take longer time to conceive, and the role of technology exists. And when both of them are falling into obstructive tubal block or Asherman's or agiospermia, then only with intervention they conceive. They will never conceive without any treatment. So every patient is a game of puzzle, and you have to slot those whole information into that puzzle so that you get a clear idea about what are the problems that are involved in. Because in infertility, you're dealing with two patients, not one, of different age, different genetic background, different working environment, different lifestyle habits, and different age. So unless you do a proper workup as a couple, why will you solve a problem? There are guidelines which says what you should do, and the American Society of Reproductive Medicine has released the guidelines named Diagnostic Evaluation of the Infertile Male, a committee's opinion. When they give a committee's opinion, that means people are not following the right way. And it says that committee is telling do this way. And go into the net and differentiate the word between a report and a guideline. A committee's report is a suggestion. A guidelines are the society saying we advise to do this way. So the components of evaluation are complete history, physical examination, a seminal analysis, depending on the requirement, an endocrine evaluation, a post-ejaculation urine analysis, in selected situations the role of ultrasonography, the specialized tests, and the genetic tests. In the reproductive history, there is something called paternal age. As the paternal age increases, the time to conception increases, the miscarriage rate is higher, and that is more a mitotic error, whereas in the female it's the meiotic error. And then the coital frequency and the duration of infertility. If somebody is 35 years, married for 1 year, it is different. Married for 5 years, it is different. The other way of looking at it is the chance of conceiving per cycle is 15%. After 12 to 24 months, it falls down to 2 to 3%, and whatever treatment we are doing, we are bringing the 2 to 3% to 15% and nothing more. Always remember that. In IVF, if you get 30%, you are multiplying with the gametes, not with your own efficiency. It's not. So the duration of infertility, if you find they have a duration of 72 months, you did not find a cause. It means you missed the cause. Saying unexplained infertility is very easy. But did you do a proper workup, and did you verify the information? Did you validate the information? And then only you can label unexplained infertility. If you did not do that, unexplained infertility is like pyrexia of unknown origin, where it's a dustbin, and it's a glorified way of saying I don't know. and childhood illness, systematic medical problems like collagen disorders, like psoriasis, rheumatoid. When they aggravated, the morphology changes. Similarly, in ulcerative colitis and Crohn's, especially in Crohn's, when the lesions are aggravated, there is a change in morphology. Similarly, uncontrolled diabetes. In previous surgeries, if a hernia mesh is used, it also affects the vascularity. When somebody has a history of hernia, ask whether mesh is used. It tells us two information: the size of the hernia, inguinal hernia, and if there's a mesh. There are studies which show, comparative studies, with the mesh and without mesh, the degree of spermatogenesis, status sperm is varied. You can do a Google search on that. Then the medication. A calcium channel blocker, Depin, affects the sperm egg interaction because it's a calcium release. Once the sperm enters into the oocyte, it releases calcium, and a calcium channel blocker inhibits. Similarly, the other drugs are there. So, asking a medical history, the sexual history, the gonadotoxins. Here in this part of the city, two gonadotoxins are: one is the steel plant, where the heat; the second is the pharmaceutical industry, where especially the units which manufacture anti-cancerous, antiviral, and antifungal, we see changes in the sperm quality. Why we did not publish that information is it provides unnecessary social issue rather than science. Where we are taking a time, what is the right time to publish it. Here the effect of paternal age on the all these things. Then the main frequency of sexual intercourse. This is a fertile couple and the probability of conception. Whereas when it comes to infertile couple, here it's a monthly coital frequency. So this is also an important factor in asking history and validating with the partner so that you know that when it comes to medical disorders, a renal failure, a Crohn's, a chronic obstructive, a liver dysfunction where the carrier proteins are altered, diabetes can all have impaired fertility. Are we asking these questions in a history? Then when it comes to drugs, antihypertensives like the calcium channel blocker, some of the antidepressants can have an effect on the ejaculation or the libido. The anti-epileptic, we are not sure whether it's a drug or the disease that's affecting the fertility, but it does. Antiviral again affects the DNA fragmentation. The finasteride that is used for male also affects the thing. A point which is other than that is when you're asking a young woman with a polycystic ovary with pimples, ask her whether the drug she is using has retinoic acid, because retinoic acid is prescribed by the dermatologist very frequently and they affect the antral follicle count. People think the pimples are going off because of the drug. What we don't realize is as ovarian reserves decrease, the amount of circulating androgens decrease. And they give tablets in a much higher dosage, and especially if they're had a history, ask that and ask them to stop it temporarily. Don't prolong the conversation because what happens then it becomes a blame game. Then in the environment, wherever the solvents are there, we should ask it. And in the pesticide industry, make a clarity whether it's fertilizers or the pesticides. And if there's a farmer, ask him how many times does he participate in the fertilization or spray himself. We never ask that question. Especially the mango, the guava. Sometimes the owner also sprays, not with the rice, but in the commercial crops sometimes because the automation has come in. It does not involve much even they are participating in that. The other thing is smoking. If an abnormal seminalysis is there with more than 5 cigarettes, it affects it. And if it is hookah, which is very prevalent in the current society, one big puff is equivalent to 200 cigarettes. Then the alcohol, if the alcohol is frequently and becomes habituated, and this is the number of units per week, then it really affects it. The other thing is asking about the co-sibling. How many brothers do they have? Does there is a family list of infertility? If there is a family list of infertility, ask how long they are married. If they are married for long duration and the index patient is also married for long duration, look at the seminalysis much more deeply to find out the causes. where the type of morphological abnormalities are similar. Before we move to the physical examination, if it is a doctor and if they're gastroenterologists, neurosurgeons, orthopedics, cardiologists, they're exposed to image intensifier. Are they getting protected and are they testing their lead shield for the quality of protection? Just wearing the lead shield is not adequate. The lead shield can be broken. Is it being verified? That's also an important aspect. In the physical examination, our work showed obesity affects male infertility, and doing a basic examination of sexual characteristics, that's the hair pattern. If the hair pattern is less, examine the breast for gynecomastia. Then the penis, the palpation of and the testicular volume. Even though it is written rectal examination, I don't practice it, but I should be doing it. The role of obesity has a major impact, and I use the organometer to measure the size of the testis because this comes with 4 ml and this is 18 ml. Indian testicular volumes are different from the Caucasians. So most of the time we get 10 to 12 ml as testicular volume, whereas the Caucasian population is 14 to 20 ml. Then even in a single undescended testis, the contralateral testis is affected. Most of the time you find abnormal sperm density. If the time to conception is past that 6 months, that means this is also a factor. And always discuss the role of orchiectomy at the undescended testis and note it down that at some time he had to go for the surgery. And if somebody is diagnosing cryptorchism and want to treat it as a fertility treatment, then it should be done at the time of the first couple of months, not later, to get the best possible results. And when you come to andrology, this is the WHO chart where you plot it. You have the second percentile, you have the 97th percentile, and this will tell you these parameters so that you know at which percentile the couple is. Then in the sperm morphology, this is the pattern you see. Then with time also study the length width, which will give you an indirect assessment of this. And now it's the 6th edition of the manual, WHO manual. Download it and try to read it. At least by the time you finish a MD exam or 1 year later, complete it. Here what happens is we also subscribe to an external quality control called UKSRM, where we get the samples from this Australian firm and then we upload it. A comparative analysis is done of each of the technician and the clinician and the embryologist. 2 people are there. They are validated internationally, and this we have been subscribing since 2012. So external quality control is also an important aspect. In the endocrine, these are the areas where you do a hormone assess, that is abnormal low counts, impaired sexual function, endocrinopathy. They ask for FSH, testosterone and TSH, and if these are abnormal, then ask for LH and free testosterone. The role of inhibin is availability issue is there. So in ultrasound, these are the all areas where you have the azoospermia, to look at the testicular volume and the blood flows. Low ejaculate, where you are supposed to do a scrotal ultrasound and a transrectal ultrasound to assess the seminal vesicles and the prostate. And in oligoacidotic with a normal testis, there you look for any testicular pathology. But as per guidelines, scrotal ultrasound is an orphan both by the gynecologist and the urologist. They also left it, we also left it. So there are no guidelines. Then epidermis is a crucial structure, and the sonologist does not describe about the epidermis but describes only the varicocele and the testicular size. So we are losing a lot of information there. And intratesticular flow, too much of emphasis on varicocele and an absence of few emphasis on the epidermis size and any calcification there. In the specialized DNA test, you have the viability. The viability is done only with 50% motility disturbance is there. The DNA fragmentation. Now practically anti-sperm antibodies has been given up because they could not find the significance or the benefit of the diagnosis or the treatment. That means at this moment our understanding is not there, so the test has been slowly given up. The leukocytes can be identified by peroxidase stain, and the sperm DNA fragmentation is similar to like this. In a normal cell, the DNA is helical. In a sperm, it is circular. It's like a bunch of bangles if together you have a circular. Then you need rubber bands to maintain the stability. And once it enters into the oocyte, again it has to unwind. The true DNA fragmentation is the packing where histones are replaced by protamides. That disturbance gives a powerful information. The sperm chromatin assay does not give it. Chromosome A3 gives it, Henlin blue gives it. That's the reason the 6th edition of the WHO manual, they have added chromosome A3 as a test. We have been doing that since 2011. So it gives the packing, and in the genetic test, karyotyping, Y chromosome deletions, also in future, aurora kinase C might come into play. We are doing some work here. And cystic fibrosis is relatively less but not absent in India. We picked up it. Y chromosome deletions, since in the beginning it was one of the tests available, they said mandatory do it, but subsequently its importance has come down, but it is not deleted from the textbook. So the role of testicular biopsy should be done only when you're trying to conserve the sperms in it, because after a biopsy there is an impaired spermatogenesis for 6 months. And the first time is the best result. So the evaluation of testicular biopsy should be joined with testicular sperm extraction. Otherwise, routine biopsy, what are you going to do with that information? If it says sperms, you're going to tell the sperms are there. If you're not there, you're as well club it with this. Only the patient is willing to go for that. Otherwise, any information which you get which you're not going to use it is unnecessary information. A combination of testicular size with FSH testosterone sometimes gives information about obstructive, non-obstructive, but it's not foolproof. Then finally, if you don't find a cause, think again and look for a cause again. That's my carry home message.